In today's video, we will discuss regarding the iron deficiency anemia. This is from chapter 102 of Harrison. It has mainly three segments in the chapter. First one is related to iron deficiency anemia. Second section in the same chapter focuses upon anemia of inflammation. And the third section is about anemia of aging. But in today's video, we will focus mainly on iron deficiency anemia because it is the commonest cause for anemia, and actually about 50% of anemia cases are due to iron deficiency. So we will understand the basic concepts, how iron deficiency anemia will manifest slowly in every individual, and how to work up what things we should not be missing during the workup of iron deficiency anemia, and the most important thing is how to treat iron deficiency anemia. For this, we will focus mainly upon few basic concepts. Most important thing is, in our body, majority of the iron requirement is for the erythropoiesis, mainly about 20 to 25 milligram of iron daily is required for erythroid precursors to produce about 200 billion RBCs on daily basis. So this is the first requirement, and some small portion of iron is required for all the cells in our body, which is critical for cell cycle, oxidative phosphorylation processes and energy production. So all these cells will get iron from one transferring molecule that is called as transferrin. It is the universal iron provider to all the cells. So from this we got to know that daily about 25 milligram of iron is required for the proper functioning of all these cells. Now, what are the sources of iron in the body which will cover this 25 milligram? When we think of daily dietary absorption, it is hardly 1 to 2 milligram. You have to remember this point. So its contribution to the daily requirement is almost negligible. Over that, there are numerous factors in the diet which will be affecting this absorption. For example, phytates and phosphates in the vegetables and cereals will inhibit the iron absorption. Similarly, tannin in tea and coffee will be again inhibiting the iron absorption. And in elderly individuals, because of chronic gastritis or usage of proton pump inhibitors, there will be poor absorption of the iron. But there are some other factors like properly maintained gastric pH or the co-intake of ascorbic acid rich food items will enhance the iron absorption. As we know, we will mainly focus upon these things during our day-to-day diet intake. So definitely, whatever the daily dietary absorption is there, it is already minimal, and because of these factors, it will be again affected. So its contribution we can consider as very much negligible. Then from where our body will be getting the iron? It is mainly from the recycling mechanism, through which about 20 to 25 milligram of the iron will be provided. So what is this recycling mechanism? There are some specialized liver and spleen macrophages. They will remove the senescent RBCs, and whatever the heme iron will be recovered from that is recycled to the plasma. And from there, again through transferrin, it will be provided to erythroid precursors as well as the other cells in the body. So this is the major source of iron. Now, once the daily requirement is met, excess iron will be stored in the form of ferritin. And where it will be stored? Mainly in the hepatocytes, splenic macrophages and duodenal cells, mainly in the cytosol. So it is kind of a reserve iron stores in the body. And this storing as well as iron absorption will be handled by a peptide called as hepcidin. This is again very important. So what hepcidin will be doing normally is, whenever there is sufficient levels of iron for all the activities of the body, hepcidin will come into action. Its level will be raised and it will block the further uptake or absorption from the duodenal cells, as well as it will block the flux of stored iron from all these storage spaces into the plasma. So it will be blocking the flux of iron into the plasma. This is normal bodily mechanism, but in some situations, hepcidin will be abnormally high or chronically elevated. So in that case, because of the lack of availability of the iron in the plasma and in turn to the required cells, there will be inhibition of RBC production leading to anemia. And this situation will be commonly seen in case of inflammations. So in inflammation, there will be abnormally elevated hepcidin leading to blockage of all these available iron, causing decreased RBC production. And in the reverse way, when there is actually increased demand for RBC production or there is already low levels of iron in the plasma, the hepcidin levels will fall to very low extent or to negligible levels. So when the hepcidin level falls, there will be no regulators for this flux of iron from the storages and there will be increased absorption from the duodenal cells. All of these will lead to increased levels of iron in the plasma, promoting RBC production. So this will be happening especially when we trigger RBC production with some agents like ESAs. Even in males, because of the testosterone, this action will be happening. So the agents like these will be inhibiting the levels of hepcidin so that there will be more availability of iron from the dietary absorption in duodenal cells as well as flux of iron from the storage into the plasma, leading to better RBC production. So the key regulator here is hepcidin and the storage form of iron is ferritin. These two are the important points. After this basic concept, now we will see what happens in iron deficiency. So iron deficiency can be absolute iron deficiency or functional iron deficiency. So what does that mean? Actually, ferritin levels in the body will be reflecting the iron stores of the body. This is first basic line. In absolute deficiency, the storage form will be actually depleted. That is, ferritin levels will be low. Whereas in functional deficiency of iron, there will be proper storage. In fact, sometimes there will be increased stored levels of iron. That is, ferritin will be normal to high, but it will not be available for erythroid precursors. So there will be restriction of iron supply for erythropoiesis. This situation we commonly see in case of inflammatory conditions. So in inflammatory conditions, to restrict the supply of iron into the plasma, this mechanism will be happening. So there will be blockage of efflux of stored irons into the plasma due to increased levels of hepcidin, which we talked in the previous slide. Now we will focus mainly upon the absolute iron deficiency, which is the topic of discussion today. So whenever there is shortage of iron, what happens? Initially, in early stages, supply to erythroid precursors is well maintained, even though the iron levels are falling. And it will be at the expense of other bodily tissues like myocytes, skeletal muscles, brain cells, even lymphocytes, immune cells, which are dependent upon iron availability. They will be compromised and whatever the iron will be available will be delivered to the erythroid precursors. But as the disease progresses and as the iron level fall further, there will be depletion of the stores. That is, ferritin, which was stored at numerous places, will start getting depleted. Levels will fall below 50 into 30 microgram per liter. Even the supply by transferrin will be reduced so that it will be reflected as fall in transferrin saturation to less than 15 to 20%. So these two numbers almost below 15 at both places we have to remember. This will indicate what? Iron stores are getting low. And in such deficient situation, later on there will be suppressed levels of hepcidin so that body will try to absorb iron from the duodenal cells. And finally, when the stores are empty and there is exhaustion of the duodenal cells to absorb iron due to fall in hepcidin level, anemia will manifest. That is, the production of RBCs and hemoglobin synthesis will be affected, manifesting as hemoglobin level lesser than the normal range. And usually, symptoms will begin when the levels fall below 8 gram per deciliter. Till then, individuals might not manifest major symptoms. Now, what are the symptoms with which this iron deficiency anemia will manifest is, we told that there will be compromise in the supply of iron to brain cells, leading to irritability, poor memory, lack of concentration and restless leg syndrome. So majority of the times, many young individuals also might be facing all these things. Even the school going children will be facing lack of concentration, poor memory, irritability and all. And we will be blaming just at their behavior. But actually when we work up, it might be due to anemia and especially iron deficiency anemia. When it comes to cardiac effects, there will be excessive strain on the cardia and we will see there will be tachycardia, and high output state will be there, high cardiac output. If not corrected at right time, it can even lead to heart failure. When it comes to skeletal muscles, it will be manifested as fatigue and exercise intolerance. Many individuals will be doing regular exercise, but they will be facing this exercise intolerance, and if we don't work up, we will not get the reason. Many a times the reason might be just iron deficiency. And the other cell which is dependent on iron is lymphocytes, the immune cells. That's why their function will also be low, leading to recurrent infections in case of anemia. And some other manifestations like nail fragility, koilonychia, spoon-shaped nails will be there, hair loss. All these things might be the manifestation of anemia, in particular iron deficiency anemia. Now, what might be the cause of iron deficiency anemia? So, whenever we get all these symptoms and we get the levels of iron studies like ferritin levels less than 15 to 30 microgram per liter and transferrin saturation below 15 to 20%, we will be suspecting iron deficiency. So, what might be the reason leading to that absolute iron low levels? So, mainly increased iron needs like growing children, adolescents, pregnancy and breastfeeding, and when we use some erythropoiesis stimulating agents. So, there will be increased iron demand, but the supply will not be matching to that, leading to iron deficiency. Or there is inadequate intake, for example vegans or vegetarian diet, mainly the red meat, whatever heme iron will be there, that will be absorbed very well and utilized by the body. But from the other sources, whatever iron will be getting, that has to be converted into the active form, and then it will be absorbed. For that, even gastric pH should be in the ideal range. So all these factors will be affecting, leading to poor absorption of the iron. And there might be malnutrition, poverty might be the reason for inadequate intake, or prolonged breastfeeding might also be the reason for inadequate intake. And there are some reasons which are affecting absorption. For example, the person who has undergone gastrectomy, bariatric surgery, or the one who is having celiac disease, H. pylori or atrophic gastritis, PPI usage, excessive intake of tea, coffee, calcium in and around the timing of iron-rich food intake can also affect the absorption. And the important reasons which we have to rule out are chronic blood losses. For example, there might be gastrointestinal cause for chronic blood loss like erosive gastritis, peptic ulcer disease, gastric polyps, hiatal hernia, angiodysplasias, even malignancies, especially in elderly, and some parasitic infections. That's why, benefit out of doubt, whenever we see a case of iron deficiency anemia in India, we have to advise for albendazole. Similarly, some urinary and pulmonary causes like intravascular hemolysis such as PNH, schistosomiasis or severe hemoptysis can also lead to iron deficiency. Especially in females, some gynecological causes like heavy menstrual bleeding, fibroids, uterine cancers, all these things should be evaluated. And some iatrogenic causes such as hemodialysis, excessive blood drawn for diagnostic testing. For example, if the individual is in ICU and all, we will be requiring nearly 40 ml of blood daily for numerous investigations. In that case also, there might be excessive blood loss leading to iron deficiency. And frequent blood donations, and even those individuals who are on some medications like aspirin, NSAIDs, antithrombotics, they might also be facing chronic blood loss. So these all reasons should be checked whenever we get a case of iron deficiency anemia. What will be the manifestations, particularly in relation to iron deficiency are, there will be fall in MCV below 80 femtoliters, and if we send for peripheral smear, it might appear as microcytic hypochromic picture, and there will be increased RDW, and as mentioned earlier, there will be fall in transferrin saturation to below 15 to 20%, and even if the facilities are available for hepcidin levels, if we send it, it will be suppressed or very low, especially in case of absolute iron deficiency. Whenever there is iron deficiency anemia, regarding blood transfusion, it is not required unless the patient is having hemodynamic instability or if there is rapid fall in the condition of patient. So unless these two are not there, no need to transfuse blood, irrespective of the hemoglobin levels. Then how to treat? We can take help of oral supplements or IV iron supplementation. When it comes to oral replacement, we know that iron tablets, mainly in the sulfate salt form, will be having 65 to 100 milligram of elemental iron. So Initially, they used to advise at least 2 tablets on daily basis, but it used to cause lots of gastritis and other dyspeptic symptoms. Even the metallic taste of the tablets will lead to non-compliance of the medication. So now what they are advising is, we have to administer these tablets on alternate days, and ideally about 80 ml of orange juice should be taken along with these tablets. This is a very good combination for the best absorption of iron. So this thing we have to advise. How long? Mainly for about 3 months. We have to advise them to take, mainly on alternate days. So when we start on these oral supplements, what we have to do is, after about 1 to 2 weeks, we have to check for few points. For example, there should be presence of reticulocytosis, and by 2 weeks, minimum 1 gram of hemoglobin rise should be seen. So these 2 points we have to check at the follow-up. If they are there, that means the individual is responding very well, and we have to continue this oral therapy for about 3 months. But in case if we don't see any reticulocytosis, or the rise in hemoglobin is less than 1 gram per deciliter, we have to consider it as improper oral absorption of iron. In that case, we have to change it to IV therapy. So when it comes to IV iron preparations, numerous formulations are available, but we have to know when to consider IV therapy, mainly when there is oral intolerance or malabsorption disorder which is already proven, or if we get to know it at 2 weeks follow-up of oral supplementation. And in case of severe anemia, for example, if the HB is less than 8, we can prefer IV supplementation. And usually in all these formulations, there will be a carbohydrate moiety which is surrounding the iron. Commonly nowadays, we are focusing upon the FCM molecule, that is ferric carboxy maltose, and it should be administered over 15 to 20 minutes of IV infusion. And the single maximum dose which we can provide is 750 to 1000 mg of iron. And for this formulation, test dose is not required. The reaction rate is less than 0.1% of cases, and usually it will be mild and self-limited. So no need to worry about this. But we can anticipate flu-like symptoms like fever, myalgia, arthralgia might be present after 2 to 5 days of infusion. So this possibility we have to keep, as well as there will be transient and asymptomatic risk of hypophosphatemia. But if the individual is chronic kidney disease patient or already having osteoporosis and all, there might be increased chances of fractures because of this hypophosphatemia. So this point we have to remember. I hope you got a clear concept regarding iron deficiency anemia. So the basic metabolism we have discussed, how the hepcidin, ferritin, transferrin will be playing their role in iron metabolism, and whenever there is initiation of this iron deficiency, how all other cells which are dependent on iron will get compromised, and later on how it will affect on the erythropoiesis leading to manifestations of anemia. Diagnostic thresholds in relation to ferritin and transferrin saturation, and the most important thing, the evaluation of numerous causes as well as treatment protocol. Mainly we can choose oral or IV supplementation based on the individual's profile as well as the severity of anemia. And remember, usually blood transfusions are not required in iron deficiency anemia. Being the most common type of anemia, everybody should be knowing very well regarding all these concepts. So please make notes of this video, share it among all your batchmates and residents who will be regularly getting the cases of iron deficiency anemia. If you have any doubts, put it in the comment section. And if this video is helpful to you, do not forget to subscribe and share it with other medicos.